I'm presenting TS, who's a 25-year-old female from Nabingo. She's single. She's a university student, and she's being taken care of by her mother and sister. She was admitted on the 12th of October. The presenting complaint was abdominal pain, which had gone on for 1 month, excessive sweating, and excessive urination. She was last well about 6 months ago when she developed anxiety attacks, and they were associated with chest pain. 5 months ago, she had a single episode of loss of vision, like a dark blanket came over her vision, and it caused her to seek help from an ophthalmologist. When the ophthalmologist had a look at her, he made a diagnosis of hypertensive retinopathy, called the physician, and she was started on antihypertensives and started attending the antihypertensive clinics. There was some improvement in her symptoms. She moved from different clinics, private institutions to others. But about 1 month ago, she developed excessive sweating, severe weakness, excessive urination, and abdominal pain. The sweating was occurring in paroxysms. It would come and go. There was no particular time during the day or night, and it was associated with a headache and palpitations. She also had excessive urination, which was mostly during the day, and normal urine color without any dysuria. The abdominal pain was sharp in nature. It was concentrated mainly in the right flank, was associated with occasional vomiting and loss of appetite, and there were no clear relieving factors. What would make it worse is pressure on the abdomen. And also, occasionally, she would have symptoms of constipation. The patient continued to seek help from private clinics who noted that BPs were poorly controlled, and further investigations were ordered for secondary causes of hypertension. She was asked to do an abdominal ultrasound because they were thinking of renal artery stenosis as one of the causes. And the findings of the abdominal ultrasound was that the renal arteries were normal. However, there was a suprarenal mass. And the suggestion was that she does an abdominal CT scan. She did an abdominal CT scan, which I'm showing here. This was before contrast. You could see there was a mass here, the kidneys over there. Here after contrast, you can clearly see the kidneys, and you can see this mass which has a central area of necrosis. I believe our radiology colleagues will expound more on that. This on the coronal view, again, you can see the mass over there, showing its position above the kidney, and also here again we see the same mass. So the diagnosis was changed to secondary hypertension, and the patient was brought to the surgical ward 3C for further evaluation and workup for possible surgery. That is the point at which we were called to assist with the management of the blood pressure. The review of other systems, I've gone through most of them. The issue in the CNS was the loss of vision, which did not recur. Otherwise, no convulsions, no history of migraine headaches or double vision. CVS, the major finding was palpitations. In the GOS, polyuria, and otherwise respiratory system was unremarkable, and in the GI, I already mentioned the pain. The past medical history was really unremarkable until this point. No chronic illnesses, no admissions, and no known drug or food allergies. In her family, she is number 13. Her mother is still alive. Father died of an unknown illness. You can see quite a number of boys. The age range is from about 46 to 25. She's the last born. This is our patient over here. Our interest in the family history was to evaluate if there was any evidence of a syndromic nature, patients who had had skin swellings, patients who are, family members who had had discoloration, café au lait, because we know of the association of phaeochromocytoma with syndromes like MEN 2A, 2B, and neurofibromatosis. However, there was no significant familial history except her brother who died. He died this year after a short illness with severe headache, may be suggestive of an adenoma. Again, people talk about the rule of 10 in phaeochromocytoma. Some recent literature is saying that maybe it might no longer be so relevant, but maybe for the students and our fellow SHOs, for the exam, you might want to remember it. Again, looking at this patient and asking, is she more syndromic? Is it more sporadic? Syndromic phaeochromocytoma tends to be bilateral, younger at presentations, fewer symptoms, milder hypertension, and has those additional clinical features. I mentioned that because it's going to lead to my impression that I made. In terms of social history, she recently graduated in information technology. She does not smoke or drink. In summary, I've presented a 25-year-old female, newly diagnosed hypertension with a history of anxiety attacks, excessive sweating, headache, palpitations, and abdominal pain. The patient has hypertensive retinopathy and a supraadrenal mass. In terms of my diagnosis at this point, I was thinking of secondary hypertension, phaeochromocytoma. I thought of drug-induced hypotension, the sweating, the weakness. She had been on amlodipine and a number of antihypertensives, so I thought of that. In terms of differentials, those were mainly differentials of palpitations, differentials of a tachycardia, like thyrotoxicosis, severe anemia. I already mentioned men and the others. Again, these are just differentials of arrhythmias. On examination, I found a patient who was sick-looking. She was weak, lying in bed. She was diaphoretic, febrile with a temperature of 37.9, mild to moderate pallor with a tinge of jaundice and no edema. She was thin and anxious. The BMI was 20, which is within normal range. Significantly, the eye examination, there was no evidence of proptosis, also no lid lag, no lid retraction. That was her visual acuity. You can see it was reduced. There was no ophthalmoplegia. On fundoscopy, the right eye significantly showed splinter hemorrhages and cotton wool spots, and the left eye had engorged vessels and AV nipping and cotton wool spots. In terms of grading hypertensive retinopathy, once you have cotton wool spots, you're talking about grade 3. Once you have papilledema, you're talking about grade 4, both of those malignant hypertension. The other examination, significantly in the CVS, her pulse was 122, small volume, it was of normal character, synchronous, and all these two pulses were felt and normal. Significantly, she had a postural drop. Her BP dropped from 90/50 when she was lying to 70/40. A drop more than 14 is considered significant. These were her BPs over the time of admission. Here, this was on the day of admission. You can see BPs are high. This is systolic. Systolic lying down is the blue line. Systolic sitting is the red line. And systolic standing is the green line. So you can see that postural drop, which was consistent throughout admission, and she really had swinging BPs. We changed the medication at this point. She was on amlodipine and losartan, and we switched her to prazosin and propranolol. Otherwise, most of the other systems were not, they were unremarkable. So my impression remains malignant hypertension, phaeochromocytoma, most likely sporadic type, and then drug-induced hypotension. Her investigations, hematologic, the significant finding here was the HP was slightly low, so she was anemic. Platelets also were slightly increased. This is her biochemistry, was essentially normal. No TSH was also normal. We want to evaluate the thyroid because we're thinking of multiglandular syndrome. In terms of her renal functions, they all seemed a bit depressed. Urea, sodium, thought maybe there was an element of fluid overload or something that was diluting her electrolytes. The calcium, we had one raised calcium. Sometimes you think of a raised calcium in case there's a medullary thyroid tumor, but we repeated the calcium and it came back normal. There was no evidence of dyslipidemia. Urine was notable for blood 3+, which is in line with malignant hypertension. Her serologies were unremarkable. Important, the metanephrines that we analyzed was the VMA, which was markedly raised over 13 times the upper limit of normal. which really, VMA is a metabolic product of epinephrine, and so you expect it to be raised in a patient with phaeochromocytoma. The ECG showed a tachycardia, and our final impression was malignant hypertension secondary to phaeochromocytoma, complicated by grade 4 hypertensive retinopathy in this patient. The patient, as I mentioned, initially was on these drugs, and we switched the patient over to prazosin, propranolol, encouraged her to take liberal salts and liberal oral fluids and IV fluids, normal saline. The patient was operated yesterday. She's admitted in the ICU. She's doing well, and post-operatively her BPs have come down. I think that is all I have for you right now. Thank you very much.